Because today's topics is oxygen therapy. I'm Dr. Shorab. Used to work as an intensivist. Today, I will give a brief knowledge about needs for oxygen therapy. First, I would like to say when you will give oxygen to a patient. First, you have to see the clinical manifestation stations. What are the clinical manifestations you should look for? Firstly, respiratory system. Within respiratory system, you should see tachypnea, dyspnea, and cyanosis. In CVS, cardiovascular system, you should look for palpitation, tachycardia, tachyarrhythmia, hypotension, angina, diaphoresis, shock. This is the main clinical manifestations of CVS. Next, come to the point CNS, central nervous system. If patient has headache, confusion, euphoria, delirium, papilledema, seizures, obtundation, or coma. In metabolic part, you should look for metabolic acidosis, lactic acidosis, sodium and water retention, and lastly, in neuromuscular part, weakness, incoordination, CO2 narcosis or astraxis, chlorosis induced asterexis, hyperreflexia, these are the clinical manifestations. First, you should go for respiratory system, where you should monitor patient is having tachypnea, dyspnea, or cyanosis. In CVS, palpitation, tachycardia, tachyarrhythmia, hypotension, angina, diaphoresis, and shock. In CNS, you should look for headache, confusion, euphoria, delirium, papilledema, seizures, subtundation, and coma. In metabolic part, lactic acidosis, whatever water retention. And in neuromuscular part, patient is having weakness, incoordination, CO2 narcosis induced asterexis, and hyperreflexia. These are the common clinical manifestation you should look for. Now comes the clinical parameters. First, you should look for patient is having hypoxia or not. Hypoxia or not. Tissue hypoxia should be confirmed by different parameters. Firstly, you should look for mixed venous PO2, which is mostly resembles to the venous PO2 or tissue PO2 level, mean tissue PO2 level, mean tissue PO2 level, which is less than 30 millimeter of mercury in hypoxia. It should be confirmed by pulmonary artery catheterization. Pulmonary artery catheterization. It would not be available in all ICUs, but you should look for basically three things. The first is PaO2, second SaO2, and third blood lactate. PO2 within 80 to 100% is, it should be less than 90% in hypoxia, it is less than 40% impending ventilatory failure, where SaO2 less than or equal to 75%, or blood lactate, the normal range within 2 millimole per liter, within 2 millimole per liter. More than 2, it should be considered hyperlactemia. Lactate level increased. There are two protocols where lactate level should be increased. One is increased production and another is decreased clearance. In ICU setting, you should look for lactate clearance by observing within 8 hours 20% equal to reduction. Every 2 hourly you should monitor lactate in sepsis patient. If the patient has more than 20%, or you should say within 8 hours, if 20% reduction is not happened, not seen in that patient, there is 22% increment of mortality to the patient. You should predict that patient mortality may increase 22% as with normals. Now comes the specific indications where you will give oxygen to the patient, or there is actual need for the patient to give oxygen. Acute state indication for O2. First, acute hypoxemia, PaO2 less than 60 millimeter of Hg mercury or 90% SiO2. Cardiac respiratory arrest. 3. Hypotension. SBP less than 100 millimeter of mercury. Low cardiac output. Now, severe metabolic acidosis where bicarbonate level less than 18 millimole per liter. Where patient is having respiratory distress, respiratory rate more than 24 per minute. These are the acute indications of oxygen therapy. Remember those 5 points. Acute hypoxemia, PO2 level less than 60 millimeter of mercury, SiO2 level less than 90%, cardiac respiratory arrest, hypotension where systolic blood pressure less than 100 millimeter of mercury, low cardiac output or metabolic acidosis where bicarbonate level is less than 18 millimeter per liter, respiratory distress, respiratory rate more than 24 per minute. These are the acute condition where you should give oxygen to a patient. And in some case, patient need continuous or long-term oxygen therapy. continuous oxygenation. What are the indications? Where will you continue oxygenation? The first, resting PO2 less than 55 millimeter of mercury, SpO2 less than 88%. This is continuous oxygen therapy, indications for continuous long-term oxygen therapy. Resting PaO2 56 to 59 millimeter of mercury with SpO2 of 89%. In case of cor pulmonale, where patient is having dependent edema, P. pulmonale in ECG, where patient is having polycythemia, where hematocrit more than 56%. You should remember the parameter what I have written. Please remember these parameters. Resting PO2 less than 55 millimeter of mercury, SpO2 less than 88%, and resting PO2 56 to 59 millimeter of mercury, SpO2 at 99%. Case of cor pulmonale, patient is having dependent edema, P. pulmonale in ECG, the stall P wave, and polycythemia where hematocrit level is more than 56%. Now I will say something about the nasal cannulas and mask with which we used to give oxygen to a patient. In case of nasal cannula, please remember these parameters. You should not give more than 1 to 5 liter per minute O2. It is not going to work. The calculation is 20% plus 1 liter into 4 equal to 2 liter into 4, 3 liter into 4, 4 liter into 5 FiO2. This is FiO2 percentage. If the patient, you will give 1 liter per minute oxygen through nasal cannula, it will calculate it as 20% plus 1 into 4, 4%, 24%. You should remember through nasal cannula, you should give a patient 1 to 5 liter per minute oxygen, not more than that. Basically, through nasal cannula, you can provide a FiO2 up to 40%, not more than that. But in reality, it is nearby 36%. It is not up to 40% also. In case of face mask, normal face mask, the volume capacity of that mask is 100 to 200 ml. You should give more than 5 liter, not less than 5 liter. It can provide up to 50% of FiO2. There are masks with reservoir. One is partial rebreather mask. Which provide FiO2 up to 70%, and non-rebreather mask up to 80%. Theoretically up to 100%, but not. It is seen that only 80% it can provide in non-rebreather mask. You should give oxygen 8 to 10 liter per minute through this, not less than that. Another device, air entrainment device. FiO2 24 to 50% it can provide as Venturi mask. And lastly, most importantly, high flow nasal oxygenation. In AR42, and there are other devices also, we can provide flow 40 to 60 liter per minute, relative humidity of 99%, temperature 37%, FiO2 21% to 100%. You can provide. It is very useful as it can wash out carbon dioxide and also provides oxygenation through HFNO. You should remember the parameters. Now lastly, I should say something very important about oxygen therapy. That is oxygen toxicity. We have seen if the patient more than or equal to 60% FiO2, vital capacity should comes down. If you keep the patient with 100% FiO2 for 4 to 5 days, patient needs mechanical ventilation, intubation and mechanical ventilation, because there is severe lung injury. Oxygen free radicals induced lung injury. The toxicity. What are those toxicity? Firstly, if a patient is having, normal patient having COPD with high PaCO2, you should not give high FiO2. You should keep FiO2 as low as possible, otherwise it will increase. Secondly, if you give oxygen more than 4 to 5 days with 100%, patient will definitely having acute lung injury. PF ratio will definitely comes down. Secondly, patient with having high FiO2 will face some different problems. Low ciliary function, low leukocyte function, and patient is having absorption atelectasis. In case of children, if you give more than 80% FiO2, in case of pediatric patient with having left hypoplastic heart, pulmonary and systemic blood will desaturated. In case of pediatric patient, if you give more oxygen, more than 60% oxygen, patient may suffers from retinopathy of prematurity. And in case of tracheostomy, bronchoscopy, low FiO2 with monitoring should be carried out, because the risk of ignition, tracheal ignition, this is the common bad part of oxygen. But still, you should give oxygen to a patient where patient needs oxygen. But one thing you should remember, oxygen is a potent arterioconstrictor. In case of MI, you should give oxygen, but you should off that oxygen without the needs, or if the patient doesn't have those acute indications of continued oxygen, you should off that, because there is acute arterioconstriction due to high FiO2, and in case of ischemia, there is already the vessels are ischemic. You should not make more constrictions to those vessels. And the last few words I should say, in case of oxygen toxicity or without toxicity, where we can't evaluate patient is having that toxic levels or not, you should continue in a case of stressed patient, where the patient is having burn, traumatized sepsis or severe sepsis, or in patient in ARDS, you should give some antioxidants to those patients for better survival. One should recommend injection vitamin C 1000 milligram IV TDS in case of ICU setting, injection vitamin E 1000 unit IV TDS. Selenium 200 microgram per day, but in burns, trauma, but in sepsis. Thousand microgram per day. The actual requirement for daily selenium is 55 microgram in normal patient, normal person. I think these are enough for the day regarding oxygen therapy, oxygen toxicity, and the precautions you should take as an antioxidant therapy. I will go all these things in details in different classes. Thank you.